Good afternoon. I'm a very new trustee of the Patients Association, but just to explain a little of what we do, it was formed almost 50 years ago, and it acts as an advocate by listening to patients and trying to lobby government and others, health authorities and provider organisations, and to work with our social care colleagues to improve health care, to ensure that information provided to patients will allow them to make decisions about their care, and really to up the game as far as the patient's voice is concerned, so that they are more actively involved and engaged in making decisions and also taking their own responsibility. Our information source largely comes from our helpline, which receives about 7,000 calls a year. Each one will take about 3/4 of an hour to deal with. And of course, given social media these days, we have loads and loads of comments coming through on Twitter and Facebooks, and we also have loads of emails. So we have a very, very rich database of the concerns that patients talk to us and our staff about. So valuable is this a database that the CQC is working with us at the moment to see what use they can make of it and of the comments that are coming through from patients. We've also recently started a pilot on casework, and we thought very long and hard about whether or not we should do this, but we found so many difficult, unresolved concerns being expressed by individuals and their carers about the ways in which they couldn't get a resolution, they couldn't get a closure, they couldn't get a proper answer from their provider or commissioner organisation to whom they were in dialogue, that we thought, well, we'd run a pilot of, say, 100 cases and see how we could enhance that communication between the two sides, or the three sides in some cases. And that has proved to be very difficult for us to do, but nevertheless we have done it because we don't have many staff, and the people who've sought our advice and help have amazingly been 100% satisfied. So it is likely that at our next board meeting the trustees will discuss whether or not we put this in as a permanent feature. We also gather and publish patients' stories. And arising from our 2011 publication of patient stories, we decided as a board to launch a campaign called Care. What were our patients saying to us? All sorts of things really, but that they wanted timely information that actually made sense to them. They wanted good communication that they could understand. And as most of you know who have been patients or clients, it's a very stressful experience. And even those of us who know most that there is to know about the service, how it operates, how it runs, can often feel completely disenfranchised from making any sort of decision and having a concrete and difficult discussion sometimes with the professionals. And so we wanted to change the environment and the atmosphere within which some of the consultations might take place. And we also wanted to make sure that where necessary, patients had advocates and helpers to help them interpret what was being said to them so that they could make decisions on their own behalf. They said that they want to be treated as individuals, and who doesn't? And they wanted to be treated with respect. They wanted to be able to express concerns without fear of reprisals. And as a chief executive of far too many years, how many times have I heard people say, well, we didn't like to complain because mum has to stay on that ward for the next X months, and, we wanted her to be fairly treated, which is devastating. Devastating for the individual, for their carer, and actually for the staff and for me to listen to, because we always tried, and one of my consultants is former consultants in the second row, we've always tried to provide an environment which was safe and express concern for the individual's health and well-being. They wanted to receive good quality care, And I'm afraid when you read the patient stories, that's the last thing some of these poor individuals did receive. They wanted innovative solutions and they wanted joined-up care. And at least in this new bill, there is an absolute requirement that we get a little more joined up. But quite frankly, we've been saying that for 40 years, and still we have not really made the universal leap to good joined up quality care. Lots of places are fantastic at it, but it's down to personalities and perseverance, and not because it is the norm. So we have launched our care campaign, and this is based on the 4 greatest concerns about patient care that are expressed to us. The first one is about communication. The second one is assistance with toileting, and quite frankly some of the tales are just horrendous. The next one is relief from pain, and the last one is to encourage adequate nutrition. Dead simple fundamentals of care, but still not being achieved universally in the services that we seek to look after us. Now today I've been asked to, from the Patients Association and the patient's views point of view, to look at how the new bill, gives patients greater choice and engages them more in decisions about planning and their own care and treatment, how to ensure commissioners and providers are well held to account, and then, of course, how to promote patient safety. Now, this will be very brief, I have to say, because there's a lot of information out there. Bills and positive rhetoric about what can and should be done and the direction of travel is fantastic. But bills will give you a sense of direction, but they won't actually achieve very much unless the people who implement it and the systems that they work within alter and change direction in order to allow them to achieve this. So it's culture change and a new style of thinking that is required. The bill, obviously, as you all know, requires patients to be put right. I'm sorry about the term patient, but that's the organisation I represent at the moment. But of course, I mean clients, carers, users, whatever. But I'm going to use the word patient, although it's a very negative term, I think. But there we are. But they are at the heart of these reforms, and they must be properly included in the design of services that they and their communities are going to use, and in decisions about what happens to them. Patients cannot do that without good information and without empowerment. As all of you know, an information standard will be published against which any patient information has to be accredited, and patients will have access to records. But so much of this all needs interpretation. So we have got to, as a service, be much, much better at properly engaging people right from day one in their care and development, knowing what their needs are, knowing exactly what they require from care, and being realistic and honest about what can and cannot be done. Because, as you all know, if people are properly engaged in a discussion right at the beginning about their care and development, even if it might be something that's going to occur in the future, they're more likely to comply and to be positive and take their own responsibility rightly for their care and well-being, which is what we need to encourage. But they do need good information, and they need it clearly enunciated to them. When I was the chief executive, I was lucky to have the postgraduate dean camped out on my campus. And I was getting a number of concerns expressed by patients, and I had patient advocates in my hospitals about the interpretation of what doctors say to you. Now, this is thousands of years ago, and I hope they've all improved. But it did mean that I could persuade the postgraduate dean to have a special course running for every single undergraduate, and because he persuaded the undergraduate dean to do this as well, and for all the postgraduates within our areas, and we covered a very wide area, to almost have them on television, having consultations with people, and to just see how they came across in terms of were they understandable, what was the reaction of these stooges that we'd set up to be as awkward as possible, so that they could better understand the consequences of their being terribly rushed or not being terribly clear, and the confusion that would be left in the minds of patients. So I would endorse better training and development, really, all along the line. I think core to whether or not this is going to work as effectively as we would all wish it to is about the role of the CCGs and their ability to manage the environment. Engaging communities and clients in decision-making is not easy. And as a health service, we have had some dramatic failures in communication in the past. I have been subject to coffins being dragged through the streets as a consequence of some of my decisions, and that's not really the right way forward. So we have got to think of much better ways to allow CCGs particularly to engage better with patients. So the Patients Association ran a summit about 3 months ago with representatives from the emerging CCGs to come forward with a blueprint for patient and community engagement, and the sorts of things that came up on a 10-point plan that can be obtained from the Patients Association was, in terms of public engagement, to make sure they were engaged in determining health needs and in planning. Now, it's not impossible. The health needs assessment that we used to do in Wales, there was a requirement to show that they had engaged each of the localities, each of the wards, and each of the groups within those wards in discussing their health needs with them and amending them if necessary, and the way in which those health needs would be met. It took time, but my goodness, it made such a difference to the quality of the outcome. So the second thing is have a successful engagement structure, particularly for those that are hard to reach. And we've seen some glowing examples, both in London and elsewhere, of how PCTs have gone out of their way to engage vulnerable and hard-to-reach groups in decisions. Certainly Newham's done it, Tower Hamlets has done it, Plymouth has done it in the southwest, and that's really, really good quality practice. We've got to train the people who sit as lay people on the CCGs really well, so the public representatives know how to challenge and address problems. We've got to engage public in the design of a public engagement strategy, because we might have great ideas, but they might think they're hopeless, really, and ensure that we have good KPIs. We have to have a good communication strategy. We need to have a clear accountability strategy for public engagement, otherwise it'll just get lost somewhere. We need to engage the public at every level of the commissioning that we do, and have really, really good information flows up and down the organisation with the public and our communities. And we have to maintain really, really good relationships with our partners. Local government is actually quite good at engaging the public and doing something about the comments they receive. Health and wellbeing boards are going to be important, and voluntary organisations are vital. But the CCGs have also got to hold the providers rigorously to account. The design of services is also important, and from my own experience, I found that engaging our expert patients and our community groups in the design of our long-term strategy for conditions in Wales made a huge difference to the way in which we were going to deliver these services, and actually to the cost. Didn't cost anything like I expected, so the Minister was absolutely delighted. And then we've got Health Watch, who, as you know, are supposed to be the champions of the patient's rights and to ensure that the patient's voice is heard. We're still awaiting the final guidance on Health Watch, but it is a positive step in the right direction, but they must be allowed to engage effectively. They have got to have money to be able to do that. They have got to have money to train and develop the teams with whom they work, and they have got to have the right sort of publicity and communications. But critical to the success of the reforms will be whether or not we're able to improve patient safety. We have got to improve care. And this is a critical piece of work for all boards. You've got to know what good looks like, and you've got to implement it where you are. You've got to innovate. You've got to monitor rigorously. Use complaints and critical incidents to inform you about what's going on. Implement the guidance that's available, and there's loads of it from Royal Colleges right the way through the innovations centres. You've got to listen to the community. The voluntary organisations will tell you what your services are. So will local authority, and so will your staff. And you've got to use patients' voices as a resource, because you're all working to inform your own judgments and decision-making to improve patient safety. You will all be judged, as we will be, on the quality of outcome for patients in the future. Patients are still confused about the consequences of the implementation of this bill, and about the fact, particularly those who live on the borders like I do, that whose system are they subject to? It might be Wales, it might be England, and where's the difference? So that's not easy to deal with. But we will be judged on our success, on how do we engage the public, how content is the public about the way in which we deliver care, a way in which we ask their views and take them properly into consideration. The way in which we improve care is an absolute prerequisite for delivering an NHS of the future, as is cost. And I know it's difficult out there, it's very difficult indeed. But we all have to do it and want to do it, and we just need to be given the tools to do it, and the patients can help.